Hi everybody, I am back with a case scenario, and this will be a way for you to figure out how to tie all the pieces together that we just discussed regarding treatment planning. So our case scenario is treatment planning for an asthmatic patient. So this is Anna P. She's 6 years, 8 months old, and she presents for a comprehensive examination. Her chief complaint, her mother reports that my child has some small cavities. So going back to our workflow that we discussed in the previous lecture on treatment planning, you want to have an overall blueprint on how you're going to approach this. A lot of times we jump right in and we go straight for the dental history and dental information, but we have to make sure that we start off with our medical history always. You want to gather that information, including any medical records that you may need. So this scenario would be no different. So you would ask about medical history. You probably will have a form that the parent fills out, and then you would just verbally review that with the parent. So in this case, Anna P has mild intermittent asthma with symptoms related to specific allergens. And for medication, she takes Singular for seasonal allergies. So medical history in asthma patients, what questions should you ask in addition to the ones that the parent just told you about on the medical history? I'll take a minute to have you all just consider your questions that you would ask for asthma, going back to your asthma lectures. What do you think is important to ask that parent? Okay, so if you know that it's very important to obtain a thorough understanding on the severity and control of asthma. So the things you should ask about is medication used for asthma control and the frequency. So mom already said that the child uses Singular. And then this frequency and severity of the episode. So how often is it happening? How severe is it? Has Anna had to go to the ER for asthma? And what symptoms does she experience with her asthma? And then are there any limitations or restrictions on any activities for Anna? Those are all things you want to ask the parent. And that can affect dental treatment in the sense that if, say, her asthma is triggered by, fear, anxiety, exertion, and she gets worked up for a dental appointment, then you may end up having her develop symptoms of asthma in the office or have an asthma attack. That's a possibility. So you always want to ask these deeper questions with the parent, and that's going to help to guide you on your treatment decisions and how you're going to manage Anna P. So one more thing to point out about asthma and oral health is that quick relief medications, including short-acting beta agonists like albuterol, are taken as needed to promptly reverse acute airflow obstruction and relieve accompanying symptoms. Increased use of asthma medication and time of the day that the asthma medication is used could lead to xerostomia, which is dry mouth. And this could be associated with the increase in caries experience in the primary dentition, as well as permanent dentition too. So it's important that you, as you're doing the medical history, you're realizing that these things that we're touching on, like her asthma, the medications that she takes, can affect her caries risk. So that's something that you want to list on maybe on your problem list as you're documenting, and as you're thinking about doing the caries risk assessment, something you want to factor in for that as well. So one more thing you want to consider beyond that is she's ASA2, and in this situation, Anna has never been hospitalized or been to the ER. So those are all good things. And mom reports again that she takes the Singular. So do you need a medical consultation for this patient? So again, mom says she's well controlled, she's never been hospitalized, and so do you think you need a medical consultation? And I'll have you think about that, why or why not. So because her symptoms appear to be mild, well controlled, medical consultation is not necessary, but you may want to ask mom about a rescue inhaler. So if Anna does use one, then you want to have mom bring that to the appointment with Anna every time she comes. And sometimes it's depending on what you're doing, say that you're going to be doing any sort of invasive procedure, you may want to have Anna take a puff of that prophylactically if it's indicated. And if you have any concerns, you could always do like a phone consult with the pediatrician. But at this point, it seems as though she has just routine asthma, that there really aren't any concerns. So you've gathered your dental history, medical history. Now it's time to move on to your dental history. This may include any previous dental records, but in this case, Anna, her chief complaint is part of dental history, right? It's dental caries, and she's never been to the dentist, so there would not be any other records to gather. Part of dental history includes her fluoridation, so her fluoride exposure. So she has optimal water fluoride exposure, and she has a high kerogenic diet. She does toothbrushing twice a day, and there's no significant family dental history. Again, we did talk about the dental history, the family dental history being something that you want to ask about to find out if there's any, familial inherited dental traits, dental issues that may come down the family line that are inherited pattern of disease in that family. So being that there's none, we've moved on. So we've covered medical, dental. Now the family psychosocial history, again, we touched on this before. So we asked about in the previous lecture on treatment planning to know what grade level the child is in. So this child is in kindergarten and she's 6 years and 8 months old. So she's on her way, hopefully, to first grade. Maybe could she possibly been retained? Or is she just an older kindergartner? So you may want to just ask the parent where she is as far as her meeting milestones. Is she reading? How's she getting along with her peers? And then mom mentions that she's involved in swimming and summer camps. That's great to hear that she's social. Parents both work as research assistants. The social economic status is mid-level, and the patient's an only child. These are all things just to gather to get more information on how Anna is and her world. And maybe some of these things you can ask about, I heard you went to summer camp. How was that? I know that you like enjoying swimming. What's your favorite stroke? These are all good things to know so you can engage the child as well. And so you capture those. The next thing would be your clinical assessment. Again, you're going to be doing all of these things and documenting it in the clinical charting in your dental, if you have electronic records or charts. You'll also be using this information to come up with your findings and your problem list. So it's all good things to observe. So again, when Anna comes in, we'll not only just be assessing her for these different areas, we also want to do a general scan to rule out abuse, looking at any burns, any abnormal gaits, just her overall interaction with mom, with your team, or also behavior management wise, is she approachable? So as you're doing your exam, you're not just looking for these things to chart and find, you're also looking at the patient as a whole. So let's look at our extra oral exam. So when we did extra oral exam on Anna, in this case, there are no clinical or significant findings. For the intraoral exam, we're going to look at soft tissue first. So this is Anna's intraoral images. If you're looking at the soft tissues, you'll see that they look, pretty pink, healthy. You're looking for any lesions that you may note, any swellings, any asymmetries, and we're seeing none of that. So there are no significant findings. Now for hard tissues, this is going to include Anna's occlusion. So you're looking at overbite, overjet, any spacing, and then you'll note any missing teeth. So in this case, her soft tissue again is within normal limits. There's moderate accumulation of plaque and oral hygiene is poor. The hard tissue, you're gonna have mixed dentition, primary maxillary right central incisor is slightly mobile. And one thing that jumps out here is that you see that she has a primary incisor present and also a permanent incisor. And normally you want to see symmetry like how you have here on the bottom where you have 24 and 25 erupted, you're missing N and Q, and you have looks like 23 and 26 erupting. When we see this asymmetry, we get concerned about why isn't this tooth exfoliated yet. The good thing is that here we know that it's mobile. For her occlusion, it's still developing, erupting, this tooth is. So you have 2 millimeters of overjet, how far it sticks out, and about a 5% overbite, how far the tooth, the maxillary incisor covers the mandibular incisor. There is an area of mild crowning. It's kind of hard to see, but her incisors here have a little bit of overlap, so we note that it's mild. And then when she bites down, we saw that her class 1 and she's class 1 for molars and canines bilaterally. And all this again will be documented in your clinical notes and findings. So again, we have here, we'll make this as our list of things that we find on our problem list, or just list in general: overbite, overjet, class 1 molars, canines, and mouth crowding. So the next thing is going to be clinical caries and any pathology that you see. So in this case, in the charting, it says that Anna has occlusal buccal caries. It's hard to see here, and that she has S has a distal occlusal caries with a broken marginal ridge, and then tooth E is present with number 9. Again, asymmetry, this is what we're noting. So under your findings, you'd have T occlusal buccal SDO caries with a broken marginal ridge, and then we would add the findings of having E. We may say that it's over retained. So we've done our clinical caries, clinical assessment. Now we're going to go on to caries risk assessment. And notice here, again, as we mentioned in the lecture, that it comes before the radiographic assessment. So what is her caries risk assessment? And we want to go back to some of the things that we talked about before. She's high risk secondary to asthma. And then in the previous portion of this, we did talk with Anna's mom, and she did let us know that Anna has a high carogenic diet. So that's another thing that we would list, and that would get us to having her have an overall high caries risk. She also had moderate plaque accumulation, and the fact that she has a lack of a dental home is also another reason that we would say she's high risk for caries as well. So if you were to use the AAPD tool that we touched on during the last lecture, that would have you touch on the fact that she has high risk, and on top of that, to top it all off, she's got dental caries. So she's a high risk patient. So radiographs, what baseline radiographs would you take on this patient? And then what are your thoughts about tooth E? That's a tooth that, again, we said is mobile, but by this point we want to have E exfoliated and have 8 present. So what are your thoughts? So what radiographs would you want to take on this patient that's 6 years and 8 months old? You can use the FDA/ADA guidelines that were shared in the previous lecture, and let me know what you think. The things that you want to think about is the dental age of this patient. So her first molars are erupted, correct? And it's her initial visit. So on a baseline, we would want to take what's recommended. So in transitional dentition, if there's contact between the posterior teeth, and she does have that, you'd want to take panoramic radiograph or selective periapical radiographs, as well as posterior bite wings. And in Anna's case, we're also going to take anterior images, maxillary anterior and mandibular anterior images to visualize those teeth. So this is what you get for Anna. What are we missing in this set of x-rays? Before we start looking at everything, what are we missing? What other x-ray would you like to take besides these two based on what was recommended? So what I would say here, so again, transitional dentition, first permanent molar erupted, I would say a pano would be indicated for this patient. And it's a simple x-ray to get on them as well. If you have a pano machine, I would recommend taking it as a baseline for this child that has a first permanent molar present. And you're mainly doing this to just do some fact finding, just to see if she has, the position of her erupting canines, if she has the presence of all her succedaneous teeth, or the teeth that are going to replace the baby teeth. So that's kind of why you want to get the panoramic x-ray. Okay, so the next thing you want to do is a radiographic interpretation. It's an essential part of the diagnostic process. So the ability to evaluate and recognize what is revealed by a radiograph enables us to detect disease lesions and conditions which can't be identified clinically. You can also make note of any pathology or abnormalities. So we're going to walk through her x-rays, and then again, this radiographic interpretation, you're going to document this in your chart. It's great to make a note of the x-rays that you take, but you also want to document what you see on those x-rays. If you don't document it, it's like you never looked. So this is what stands out here. So in this maxillary periapical or maxillary occlusal, we see that she has a little bit of a lesion here above this lateral incisor tooth D. It looks like it's calcified, it's well defined, so we would make sure we note that in our chart. And then here we mentioned before that tooth E is retained. The great thing is that we see that there's resorption of the root, so that's good, it's loose, so that's just something that we want to note. And here it's hard to make this out, but we're going to identify that this area here has a fractured marginal ridge and has is what we're noting as decay. So those things you want to put into your findings inside the clinical chart. It's going to be generated as part of your, now becomes part of your problem list as well for this patient. So radiographic summary, so 2 bite rings radiographs and 1 maxillary and 1 mandibular periapical were taken. A retained primary tooth and radiograph, sorry, 1 maxillary and periapical was taken, no mandibular, sorry, was taken. A retained primary tooth in a radio-opaque area apical to tooth B. You'd want to note that in your charts. No other radiographs were taken at this time, and we had mentioned we wanted a pan, and the reason was is this Anna's mom did not want to have additional radiation exposure. So you may want to have in your office just some sort of scripting for your staff to just tell them the amount of radiation that's present in the x-rays. If you have digital x-rays, are very minimal, and the value of having an image is important for in the case of Anna, because she already has a few issues here where she has this supernumerary tooth or periapical radiolucency or radio opacity associated with tooth D. She may have other areas in the mouth. So you want to make sure we have a good image of all the mouth. So it's good to have that. So the patient will have a panel taken in a future recall, and the maxillary anterior periapical radiograph as indicated to monitor emergence of tooth number 8. So that's something good to look at. So 8 is coming through, as we mentioned before. I just want to monitor it with additional images. So moving on, the problem list. So in the last time we lectured about the treatment planning, all your findings, from your radiographs, from your clinical assessment, caries risk assessment, med history, dental history, these are all gonna, and your caries risk assessment, these are all gonna now become part of your problem list. So what would be Anna's problem list? So mild asthma, you want to include that because that's something that we have to consider. That Anna's overweight, which I probably didn't mention before. I'm now seeing it on this slide, but it's good to definitely, as dentists, tackle obesity and be comfortable with counseling parents on nutrition and diet, because they both feed into being patients that are overweight, and also sometimes the diet that things that they're eating or drinking or consuming can also lead to dental caries. So it's kind of 2 birds, 1 stone. Same conversation about the effects of diet on both weight and also dental caries. So in Anna's case, she does have caries, SDOT, occlusal, and then the pathology that we noted, the apical pathology to tooth D. She has some mild crowding and she has a high caries risk. So implications of medical history, we did talk about asthma contributing to overall caries risk. And then we have some possible intra and extra-oral concerns with asthmatic patients. They tend to be mouth breathers. They have reduced salivary flow. Look at my Zoom. I think I just got disconnected. Sorry, you all. So these are all things to consider. Candidiasis, gingivitis, overweight children can be susceptible to secondary problems, including hypertension, diabetes, increased caries risk. Appropriate diet and patient referral should be considered when necessary. So again, you have all this problem list. You're going to want to tackle it item by item and make these considerations, educate the parent on the implications of Anna's asthma. A lot of kids have asthma and parents probably aren't aware that it does have some sequelae as listed. So the next thing we want to move on to is, what is your treatment plan? So you should include exam, prophy, recall, radiographs, and restorative. So what would be your treatment plan for Anna? Let's start off with just from the exam standpoint, and then prophies, what do we want to do as far as cleaning? How often do you want to see her? That's recall. Radiographs in the future, we already kind of touched on that, and then restorative. So just give some thought about what would be your preliminary treatment plan, and we can go back to the slide before that talks about her problem list. How would you tackle the care that you provide for Anna? So treatment plan. First, you want to establish a dental home for Anna, right? So you want to make sure that mom is aware this is a place that she can come and receive her care. And we really want to link her to a dental home so that, she's 6 years, 8 months. We should be seeing her. We should have seen her from before, right? But we want to have ongoing care with Anna, ongoing conversations, a place where she can get prevention, education, And if she ever has any issues, trauma and so forth, she can come and seek care with you. So we want to make sure that the mom understands, Anna's mom understands the importance of having a dental home. So preventative treatment, so the dental prophylaxis is just a cleaning, and fluoride treatment, you would want to perform that on the day of the visit. And then review oral hygiene with the parent and the child at the beginning of treatment and at subsequent visits. On this appointment, even though we didn't mention it, Anna does have her first molars present, and we like to do same-day sealants. So sealants, you know, I've lectured on that, really are one of the most underutilized preventative modalities, and they're shown to really reduce the risk for caries on the occlusal surface of permanent molars. And in Anna's case, I definitely believe she would be a great candidate for sealant. So, you know, that's if mom has no financial concerns, and it seems like she may have some because of the fact that mom did not want the pano. Not just also, you know, radiation was a concern, but also money may have been a concern as well. But if Anna is cooperative and finances are not a concern and you're able to promote this to mom, I would recommend that on the first appointment that you go ahead and push for mom to allow you to do sealants on Anna's first permanent molars. And then what referrals will this patient need? So we already talked about some of Anna's issues related to her obesity, and we may want to consider how we loop her into maybe a nutritionist if that's possible, or we maybe consult with her pediatrician. But we also want to focus on the fact that Anna has that pathology that's apical to tooth B. So we would probably want to loop Anna into an oral surgeon when possible. And I know that a lot of times it's tough to do that in Jamaica. You have limited oral surgeons available, but it may be worth it to at least recommend that to the parent and document that you recommended the oral surgeon consult to evaluate possible supernumerary or odontoma. Documenting that is important in your records, so I would definitely say initiate the referral, and then you're also going to follow that progression of that tooth, how it develops over time with imaging periodically as Anna returns. So what would be your treatment plan? So again, Anna does have sealants to do. She does have some cavities to do. So I've listed a few options. So the first option is if patient is unable to have them completed at the first appointment, then you may have some additional options, but you want to recommend sealants. So sealants 3, 14, 19, and 30. If they weren't able to get at the very first appointment, then you may just bring her back for sealants only. That would be just having an easy appointment with Anna, especially if she's anxious, something that you can do that doesn't involve anything that's invasive. If finances and cooperation are concerned, then you could just do maybe 2 sealants, 3 and 14. That's doing the, the upper quadrant first, or 19 and 30, whatever you recommend for that parent, just tackling 2 at a time. You could even do 3 and 30 together, so you're doing one half of the mouth as well. That's another great approach, or 14 and 19 together. So the other thing you could do is quadrant dentistry. And again, this is what we recommend, right? Quadrant dentistry to tackle the restorative care that's needed. And so if she's cooperative and say that this was her chief complaint, you may say to mom, hey, I want to bring Anna back and get straight to doing her cavities. Anna's pretty cooperative. I'm not concerned about her behavior. We'll go ahead and tackle that quadrant. We'll do, the filling on the tooth that has the fracture. We'll also do the filling on the tooth next to it, and then we'll seal the tooth beside that. Or you could just, also do all the remaining sealants. It's really up to what Anna can handle and what mom is comfortable with financially. So these are some options. You may come up with your own as you're managing that patient, and she's in your chair. You may have a different approach. These are some different ways to tackle a treatment plan. The last thing you want to consider is the recall. So monitoring growth and development with special attention to exfoliation of E and subsequent emergence of number 8. Consider an orthodontic consult. And why is this? Because you had some mouth crowding. So the patient will have a panoramic radiograph later for monitoring growth and development. So that's great. You can reassess. And you want to recommend, I recommend a fluoride mouth rinse because she had the caries interproximally and it did fracture. Other adjuncts for the caries risk assessment tool is something as well that you could recommend, whether it be the mouth rinse or maybe having her come back in for in-office fluoride treatment. But I definitely think a mouth rinse may be more practical. And you want to have a recall at 6 months and every 6 months after that. So every 6 months you would see Anna. And because of her caries risk, would you take additional imaging? So go ahead and look at the FDA ADA guidelines and tell me what you think based on her caries risk. So if you've had a chance to look, she's high caries risk, and I would recommend imaging in 6 months when she comes back in 6 months, just to make sure there's no additional lesions. Plus, you can also take a look at the work that you did to make sure that it still looks good and that there's no recurrent issues, caries, and that you're happy with what was performed. So again, this is just a takeoff of what we discussed in the previous lectures, kind of a place that we started in the lecture on treatment planning and just bringing it back to that. We worked our way through for Anna with evaluating, getting information and gathering it, talking about our findings, generating a problem list and diagnoses, and then certain modifiers of how we approach treatment. You know, we look through the lens of patient behavior, parents, financial circumstances, and so forth. And then looking at maintenance, monitoring, and prevention. So this is pretty much everything I had to lecture on today. If you have any other questions or concerns, you're welcome to shoot me an email. Thank you so much for your time and attention. Take care. Good luck with your exams.